First, I just want to thank you for coming to this session on ACOs, accountable care organizations, and integrated care management opportunities for nephrologists in the future healthcare model. I'm going to spend about 3 or 4 minutes providing some context for you. First of all, healthcare reform, which has been highly touted in the lay press as well as in our literature, really is focused on access to care for the 30 to 40 million people who don't have health care or health insurance. But when you think about access to care, as you know, as we bring all these people into the healthcare delivery arena, we need to think about new ways of organizing care, of delivering care, and at the end of the day, the way care is financed will really drive the way it's delivered. And in fact, what healthcare reform really is doing is looking at access for those 30-some million people who don't have care, looking at reimbursement, because bringing people into the system clearly raises the issue of how we're going to pay for this, and alternate payment structures like accountable care organizations are going to be critically important to constraining the costs while continuing to drive the highest quality of outcomes. There could be no other condition than chronic kidney disease and end-stage renal disease that would be suitable for an accountable care organization. And such a structure really has the potential to transform the care of patients with kidney disease. First of all, clearly the population is big enough for this to matter, whether it's the number of patients or the huge expense. ESRD and CKD patients represent 1% of all Medicare patients and consume up to 10% of all Medicare dollars. Secondly, our current fee-for-service system clearly has gaps, not only in the care coordination, but in reimbursement to providers for the services they provide, including nephrologists. In addition, we have a well-defined set of conditions. CKD is well-defined based on agreed-upon laboratory criteria, and there is a continuum of disease from late-stage CKD into ESRD, so there's no ambiguity about who might be eligible to participate in such a structure. Finally, Kaiser, Health Options, Fresenius, and DaVita all have extensive experience conducting demonstration projects using integrated care management techniques and have shown in aggregate substantial improvement in important intermediate outcomes, significant decreases in unnecessary hospitalizations, and decreases in total costs of care. So we know this approach to delivering care works. And finally, we have enough experience in the renal community to scale this to the extent it needs to be scaled if this is going to be successful. We know we have a very complex population that is crying out for care coordination. We know that nephrologists already serve as principal care providers, and you're going to be hearing more about a number of these things in a minute. And we know that there are proven interventions to control unnecessary hospitalizations, improve clinical outcomes, and control costs. The reason we're so excited about the opportunity of ACOs is not just that we believe that this method of delivering care can improve outcomes and save money, but the perfect storm has occurred, and in the healthcare reform legislation is specific language regarding accountable care organizations. And I know you all have been approached by hospital systems or multi-specialty groups or others who are thinking about starting ACOs and want to see how nephrologists can participate in these. What we do know is that regulations will be issued by CMS that will define how ACOs need to be structured and how they will function beginning in 2012, and that these regulations likely will be issued either in December of this year or January of 2011. So this is not just theoretical. This is actually a new approach to delivering and financing care that requires a partnership between physicians and other providers, and is going to happen.